Yeah, we're running a virtual design school. So we've built off of our virtual sprint school that we ran last spring, and we're going to take everybody through 7 sessions with these really awesome speakers. I can't wait to get it started because I'm kind of floored by the number of people that have signed up already in one day. So
how many?
100,
Details.
118 or 122. I think it was 122, and it's only been up for less than 24 hours. So I sent out.
We should. Ali's like, we should have charged for this damn thing. We could make millions.
But it's really good. There's lots of people from a lot of people from NHS, people from BC, a lot from Toronto.
Ooh.
So that's why I think, Marlies, we should fire this off to the ILN. Get them up there.
Oh, brilliant.
Okay. So I forwarded it to you to hopefully forward to somebody from there, because I believe they have your name and everything, right?
Right. Comprende. Mm-hmm. Okay. Doing it.
Boom.
Hi, Shy. She's like, oh, I'm muted. Where's my mute button?
That's exactly what I'm doing. Hi, Marlies.
Nice to see you.
Nice to hear from you and see you too.
So Shai, tell the world what you do in like 10 seconds or less.
Sure. So hi, everybody. Good morning. My name is Shai Amlani, and I am the Provincial Director with AHS for Virtual Health. And so essentially in less than 10 seconds, that means that we're helping people to integrate technology into their day-to-day service delivery.
That is amazing. So I just love that you were able to come, Shai, because I'm sure that you have a lot to contribute.
We've got some people from my team here too, Marlies.
Oh, very nice, very nice. All right, I have 10:02, which for me is officially a reasonable time to start. So my name is Marlies van Dijk. For those of you that don't know me, I'm with the Design Lab of AHS. We've been around for 3 years. Richard, September is 3-year anniversary. We'll have to have a party.
So I get a pen.
Pardon?
Do I get a pen or a ID badge holder? Or?
You get a little pin, yeah. One of those ugly gold things. I wanted to let you know that I was in Toronto in the spring, and I met someone by the name of Bregje Heuvel. That's the Dutch way of saying it. Apparently you say Bregje, and I saw her in the lobby speaking Dutch, and I was like, oh, so cool, there's a Dutch person here. You know, we all kind of glommed together like a pact. So I ended up meeting her because she's working with St. Elizabeth Futures, SE Futures Lab out of Toronto. And she did a study on the Homespital, and she's looked worldwide to see what the latest movement has been. And she also knows the Canadian context, even though she's Dutch. And she worked with Zaina at SE Futures, and I think Zaina might be on the line as well. Are you there, Zaina? 29 callers in. This is amazing for summer. All right, Bregje, I want to let you introduce yourself a little bit more, and then the idea is that we're going to do a short presentations and have some Q&A in between. Make sure you know where your mute button is. This call will be recorded. And Ali gave me the thumbs up. It's recorded. So Bregje, please take it away. I'll pass it to you.
Yeah, hi everyone. Thank you so much for joining us. I'm honored to share all my work with you. As Marlies said, my name is Bregje. When I was in Canada, it was very difficult for people to pronounce my name. So be Bregje, whatever works for you, it's good. As she said, I'm going to share my research with you. There will be a Q&A at the end, but feel free just to ask questions during the presentation. I hope I can see the chat. I'm not completely sure. Otherwise, just unmute yourself, and that would be good as well.
So I can even alert you, Bregje, or just take a couple pauses once in a while.
Yeah, I'll try.
Okay.
Okay. Let me see. Does it work? Yeah. Okay. So the Netherlands. It's that tiny, tiny red country you see on the map here. Like compared to Canada, I think Canada is 240 times bigger. So we're a tiny country. And And in that tiny country, I study at the Radboud University. My background is in medical biology and human biology, but I specialized in management and innovation. And this picture is a quite typical picture of the ambience. We love to bike in the Netherlands. But I wanted to broaden my horizon, so I decided to come to Canada to do my graduating piece, my master thesis. And I worked for SE Health. I think most of you know SE Health. Just to make sure, I'll give a little bit of a summary. So SE Health is Canada's largest home care company. They're a social enterprise, so not for profit. And they are 110 years old. So they started with 4 community nurses in 1908. And they have grown to over 9,000 staff. And what I like about this company, what attracted me, was the fact that they have been innovating since the beginning. So they were the first to deliver chemotherapy in the home, and the first to provide community-based care for people living with HIV and AIDS. So I came to the company, but what really inspired me was this article from my supervisor, Zena Kayat. And she wrote the article, "Home is where the health is." And this started my Homespital research. And Homespital is, instead of hospital, Homespital. So it captures the shift from health services delivered in an institution or in a clinic or in a hospital to being delivered at home. And I think this addresses the many challenges we face today, because it's often cheaper, it is less risky for the elderly, and there's more access to care. So that is what started my research. What did I exactly do? So my question was, which Homespital solutions are currently possible? I did a literature study, I did a lot of interviews, and I came to 5 categories of Homespital solutions. The categories were diagnostics at home, hospital to home, infusion services, mental health, and other. So I'm going to share with you 20 solutions out of those buckets. And we'll start with diagnostics at home. So currently there are more than 4,000 different diagnostic tests available. And imagine if you can do all those tests at home. So in the first bucket, I will talk about 5 of those options. The first one is sample testing. And this one includes screening for HPV, something Eve Medical does, microbiome testing, Ubiome does this, or urinalysis, like healthy.io. The urinalysis you see here from healthy.io. So in the current situation, you think you have a urinary tract infection, or you have something that you have to test your urine. You have to go to the doctor, you get a cup, it's very uncomfortable. You have to pee in it, you have to bring it back. Someone has to stick it, the doctor has to look at the results, and it takes a lot of time. Sometimes you're being sent home to wait for a call. Maybe you get medication, you have to go to the pharmacy again. Very uncomfortable. So what healthy.io does is you have an app or a website. You can order a self-sampling online, and you just you pee in a cup in your own home, you stick it, you have, on the picture you see the stick, you put it on the card that's beside it, you read the results with your smartphone, you send a picture, it comes directly in your existing EMR, your doctor can see the results, and they will call you when they reviewed it. So this way, it's way less of the disruption of your daily life. And I immediately had to think of my grandma, who had to do this test like once a month, very uncomfortable. So this is a quick and easy way to test it. The second one is home imaging. So the picture you see here is a portable ultrasound device. It's called Butterfly. So the nurse can just put it into her smartphone. It's just a little bit bigger than a smartphone, and can go to your house to do the imaging. Philips made a similar device called the Lumify. But what I find even more interesting is a new company called Open Water. They are currently developing a portable MRI. So an MRI, the size of a ski hat, and a normal MRI is between, the whole system is between 30,000 and 500,000 euros. And Open Water's MRI claim that they can make it 1,000 times cheaper. So portable, very cheap. They haven't produced it yet, but I'm very curious at what it can do.
What size is it? It's the size of like a helmet.
Yeah, a helmet's kind of size.
Ski
Yeah.
helmet. Okay. Fascinating, because we're working on a project with DI wait times. I'll bring this up. Thank you.
Okay, so another diagnostics at home is phlebotomy. So this can mean multiple things. Like the first most simple thing is just a phlebotomy service at home. So for example, Life Labs does this. For $60, you have to pay out of pocket for it. But for $60, the phlebotomist comes to your home and collects the samples, takes it to the lab. Something different you have seen in the recent years is the paper-based blood collection. So what you do, you have a finger prick, a drop of blood on a piece of paper, and either you analyze it with your smartphone, because on a color spectrum to see which color it gets, or you have to send that back to the lab. And that has been done a little bit. But what I find most interesting is a new technology. It's called the HemoLink. And it's from the company Tasso. And that's the one you can see on the picture here. So you get it in the mail. You put it on your arm. You click the big red button. And with 4 microneedles and a kind of like vacuum, it collects blood in just a few minutes. So you can send it back to the lab and receive your results on your smartphone. And this is all like nearly painless. You can do it while you do something else. So not traumatic at all. While you know that a lot of people have, a kind of fear to do the blood testing, this will be a good way to avoid that. Sleep testing. So the current standard for sleep testing is being done at the sleep lab. You have to go there, you're connected to a lot of cords and expected to sleep in a complete strange environment. And it's not comfortable. I heard many stories about people that say there are lights everywhere, people are walking around. And even with those tests, sleep apnea is only diagnosed in like 20% of the cases, because we don't even have enough capacity to do all those sleep tests. So with sleep testing at home, you can do it in your own environment. It's way more comfortable, and the data actually represents your normal sleep pattern. And another big plus of this is that you can do it multiple nights in a row. And for example, what you see here is a device with cords, but Bregje, it's a company from Toronto. They actually made one which is completely cordless. So it's kind of a mask that goes over your mouth and nose. You just pull it back, like the things they have in the airplane, that kind. And it's completely cordless, so it's even easier to do. And the last of the diagnostic tests that I wanted to go through is vision testing. As you can see here on the slide, it's with your smartphone, a cheap add-on, and you can test your vision at home. So it can test nearsightedness, farsightedness, cataracts, and astigmatism. And the test is self-managed, so you don't need any help, and the results are interpreted by AI. And these are some of the companies that do that: IQ, Peak, iNetra. So that were...
Wow. Yeah. There's a lot happening here. A little bit surprised. Yeah. Any questions from the group? We're taking a quick breath. Unmute your line if you have a question.
How did you find all these?
A lot of literature research. So I did a lot of research online, but also because SE Futures and SE Health is a big company, and a lot of companies actually want to do trials there. So we also have a database of all the companies that contact us, and like the list with thousands on it. I went through all of them. So I spoke about like 5 different diagnostics just now, and I did a kind of market analysis because there were only a few companies I talked about, and I put it in this graph. I won't say it's comprehensive, but it will give you an overview. So what I did in this graph, in this table, is the first part is the company name. The second part is it in vivo or in vitro? So in vivo, is it imaging? Is it cognitive testing, that kind of stuff? Or is it in vitro? Do you have a sample, your saliva, your urine? Then I made a distinction between do you need a clinician to use it, or can a patient do it completely themselves? The scope, can you diagnose a wide scope of diseases with it, or just very specific? Ease of use. Do you use a smartphone app to diagnose? And do you actually send the sample to a third party? For example, the paper-based blood test you can either do with your phone, or you can send it to a third party. So this is quite a lot. I try to make it more visual with this graph. It's still a lot, to be honest. So if you look at this, you have to see it as 2 different parts. The left part is the diagnostics at home that can be used by clinicians, and the right part is for the clients. So let's start at the left. So you have the high screening abilities and the low screening abilities, and the low ease of use and the high ease of use. For example, live labs, it's phlebotomy, or it is a blood testing. So it can diagnose a quite wide range of diseases. However, doing phlebotomy for the first time in someone else's home is quite uncomfortable, because when you do it somewhere else, in a clinic or in the hospital, there's always someone to fall back on. If you don't get it the first time, you switch to someone else. So that's why it scores high on the screening abilities, but quite low on the ease of use. For example, what you see a little bit lower, a little bit more to the right, is Winterlight Labs. They are cognitive testing. They have a cognitive test. So the ease of use is very easy. They only have to be there to administrate, but they don't have to actually prick the patient or do anything else. But the scope is a lot lower. If you go to the right side, for example, we have color genomics. Is a genetic test. They have a high screening ability, and it's very easy to use. You order something online, you just have to swap, you send it back, you get it through an app, you can see everything, you get a doctor if you want them. And if you go lower to biodiscovery, it's lower and a little bit more to the left. That is, for example, microbiome. So in current times, it doesn't say too much yet, maybe more in the future. And it has a lower ease of use because you have to take a sample multiple times each month. So that's a little bit of explaining how I did this market analysis. Are there any questions here?
There's a lot more happening than I thought. That's my first reaction.
Well, I'm happy to hear that. And at least I've told some things that are new.
Exactly. Keep going.
Okay. So, second bucket, hospital to home. This bucket is not so much about new technology, but more about the service delivery. The first thing is early discharge. I don't know if you know about Women's College Hospital, but it's a hospital without beds. So a hospital designed to keep people out of the hospital. And they specialize in same-day surgery. Another example you can do with early discharge is stem cell infusion recovery. Normally, the patient stays in the hospital for up to 2 weeks until the stem cells recover, but it can be done at home. The only thing, it has to be enabled by other technologies, like, for example, the phlebotomy we talked about, or virtual care. Another thing that's quite important is palliative care at home. There are a lot of studies on this, that like 65% of patients have a preference to die at home. but that instead 65% of people die in hospitals. And again, with telemedicine, palliative care could be done at home, which allows for more comfort, privacy, quality time with loved ones. And this is a great opportunity to test other technology as well. For example, VR for pain medication, pain treatment. The third one is reactivation. So, for example, SE Health does reactivation already, for example, with their Hillcrest facility. But in my opinion, reactivation should be done at home. That way it can be tailored around their everyday life and their environment. So, for example, if the home has some difficult stairs or other obstacles, reactivation can be done specifically around those everyday obstacles. And there has been studies that you don't even need that kind of difficult devices to actually do the reactivation. A lot of reactivation can actually be done with the stuff you already have at home. And then the last one, from hospital to home, is surgery at home. So instead of bringing the patient to the operating room, you can bring the operating room to the patient. So a van or a truck is outfitted with a surgical unit. This one is actually quite large. I've seen a lot of that are a little smaller. And this one just drives to your drive, it parks on your driveway, and the patient can just like put on the bathrobe, get out of bed, walk in.
Oh, this is insane.
Yeah.
We thought a stroke ambulance was forward thinking. Okay.
So I like this one because it allows for better access. It can be in remote areas, but it can also be used, for example, when hospitals have longer wait times. So for a while it belongs to that hospital, for another, then a month later it goes to another place, and it increases their capacity without having to build a complete new OR. So yeah. The third bucket is infusion services. I looked at 3 different infusion services. First one is chemotherapy, hemodialysis, and other IV drips. Other IV drips, you can think of pain medication, antibiotics, just simple fluids. And what I like about this is that it improves quality of life and is a lot less disruption of the daily life. Because, for example, the dialysis can be done at night while the patient is sleeping. And while SE Health did chemotherapy before, they started in 1981, they stopped later on because of the logistics, and it was increasingly difficult. But good news, there are a lot of companies working on that, because this is from the company Outset. On the left, you can see how the devices looked a few years ago, and on the right you can see what Outset developed. And it's a easy portable dialysis machine, and it purifies the water, it produces fluids that are needed in real time, and takes the patient's blood pressure. So it only needs access to water and an electrical outlet. Fourth bucket. Mental health. So everyone knows mental health problems have been increasing extremely these last years. Currently, they're saying 1 in 5 Canadians experience a mental health problem or illness, and that approximately costs the economy like 50 billion a year. So definitely a hot topic. There are 3 things I found about mental health. First one is cognitive testing. So instead of having to do the paper-based tests at the doctor's office, like the mini mental status examination, cognitive testing can be done digitally. So there are different sorts, like different technologies. The first one is, for example, interactive real-world activities. Brain Effects is working on that. Winterlight Labs, does it using speech analysis. So the advantage of this is that it can be done multiple times. You can do it every 2 weeks, every month, and you can see the progress, while the tests at the doctor's office can only be done once or twice a year. Mental health online. I don't know if you've heard of the Big White Wall. It's a big thing in Ontario right now. So instead of doing reactive mental health care and like waiting till you have a problem, go through a psychologist, having to wait a few weeks before you, I don't know if it's the same in Canada, but here, if you want to go somewhere, you have to wait a few weeks for you even have your first appointment. So with mental health online, you can do it proactively. So as I said, Big White Wall is an example, and it has self-help programs, creative outlets, community platform. Most importantly is you can access it continuously. So wherever you are, if you're waiting for the train, if you're on your work, even on the toilet, wherever you are, you can access it. And Big White Wall already has a province-wide partnership with Ontario Telemedicine Network and with the Ministry of Health. So it's definitely getting there. Last one for mental health is VR therapy. So virtual reality can stimulate any environment, and it can be used for behavioral therapy like phobias, autism, but also importantly, social isolation. So what is extremely beneficial from this kind of therapy is that it can provide gradual exposure. So the therapist can change the complete environment just for that one person. And even better, it's more practical. Let's say you have a fear of flying. You can't take your therapist on the plane with you every single time you have an appointment. But with this kind of thing, you can stimulate, how do you say it? Yeah, recreate.
Simulate.
That was the word, sorry.
Just a T,
Simulate, yeah. Simulate the whole thing. And what's the beauty of this is that, for example, if you're looking at interaction with people, you can even freeze the environment as a therapist say, hi, look at that specific detail. And you can personalize the whole care for the patient. I'm going way too fast. I'm hoping you can still, that I'm not talking too fast because I'm going through the slides very quickly.
We're good. We all have ADD over here, so just keep on going.
Good. So last bucket already is other. So this is actually the bucket that I couldn't, nothing fit in the other bucket. So this is the other bucket. First one is the ambulance drone. It's actually something that they designed in the Netherlands at the Eindhoven Technische Universiteit. And there are different versions, but the one you see here is quite simple. It only has a defibrillator. And but you have more advanced ones, for example, with a screen. And that way, when the ambulance drone arrives, the bystander can talk to the doctor and can be guided. The doctor can see the patient and guide through the whole process. And important that they can improve access, so where the ambulance can go to very easily. And it decreases the waiting time. And since reducing the time to defibrillation is the most important factor for increasing survival, this can save a lot of lives. ER diversion. I heard you were also interested in this solution, if I'm correct?
That's right, especially for frail elderly.
Yeah. So an estimation of 65% of all visits to the emergency room don't have to be there. So that's an extremely high percentage. So ER diversion is very important. I'll take you through 3 of the programs that I found during my research. The first one is actually one from SE Health and with partnership with Sunnybrook Hospital. So in gray, you see the normal journey, and in red, you see the first 48 hours. That's how we call the program. So an elderly person comes to the emergency room. Normally they assess him, stabilize him, treat him. But because of the treatment, he probably has to be admitted and stay overnight. And before the patient can actually be discharged, he has been there for way too long. Like every single minute, the elderly person doesn't have to be in the hospital. It's too long. And they come at risk for ALC, alternative level of care. So what this program is that parallel to the assessment and stabilization, there will be a determination if the patient's healthcare needs can be managed and treated in the home. And whatever the time, even if it's 11 o'clock at night, a PSW, I don't know if you have the same terms, a personal support worker, will meet the patient in the emergency room, take him from there, travel alongside him, and settle him in at home. And that PSW will make sure that the patient gets interdisciplinary team that works up to 48 hours or until a new home care team can be established. So the point of this is that to get someone to that patient as soon as possible and take him out before he's even admitted. Another program is from Hamilton, and it's provincially funded. It's a frequent flyer program. So frequent flyers are mainly seniors with chronic conditions living in their own homes. And they call 911 up to 90 times a year. So that's a very high amount. And what they do in Hamilton is that they have proactive house visits from paramedics. And with those proactive house visits, where they also look at the environment, where they live, whatever they can do, they reduce 911 calls by 40%. And the last program that I wanted to talk to you about, like last ER diversion program that I wanted to talk to you about was Dispatch Health. This is a program from the US. Unfortunately, it's not in Canada or in Europe yet. And it's a mobile urgent care program. So normal journey, patient has to drive to the ER if something happens, and the average wait time is 4 hours. Extremely long, not comfortable. And instead, you can either through the website or a call or the app, you can request a service and they will be at your house within an hour. But unfortunately, it's not, it's only in America right now. Just wondering, any questions yet?
I'm sure we'll have a lot, but
Okay.
it sounds like you're almost close to the end.
Yeah, I'll get there, yeah. Okay, so the third one from the other bucket is very simple. It's very low tech. It's just a service. But right now, you get your vaccinations either at the doctor's office, at the pharmacy, but SC Health is a home care company, so if those home care nurses are going to the home of that elderly patient anyway, why not just take that vaccine with them and reduce touch points and increase access? So very simple one, but even those we have to put in here. This one I like a lot. It's from Science 37, it's a company, and they do virtual trials. So instead of having a clinical trial site, like a hospital, participants can enroll and give consent online. And they receive their study drugs directly to their house. And through wearables, all the collection of data is completely remotely. So the very big advantage of this is the time span, because within weeks, you have enough people to participate, which can take a year or even more within a normal clinical trial. And you have a bigger reach because people can join more easily because there are less constraints. You don't have to miss work, you don't have to travel. So I really like this one. And it's been already been tested with a few big pharmaceutical companies. So I'm sure we'll hear more about this as well. And last, but definitely not least, is vital signs monitoring. That one can be missed. We're all familiar to the Apple Watch or the Fitbit. And with sensors and wearables, you can measure biomarkers continuously and passively instead of actually having to go to the doctor's office to measure your blood pressure, and you're stressed out. So is it even the right monitoring? And the nice thing about this is that I have so much more data, which allows for timely intervention. If you couple this with AI, they can see so much things that the human won't be able to recognize. And you have such little variance that we can see that will make a difference here. And it's expected that by 2020, there will be 50 billion connected devices. So a lot of data. Also for this one, I did market analysis. I have 19 companies here that I looked at. Same, at the left, we're starting with the company name. Then I looked at the type of device, because there are a lot of different things. The D stands for multiple devices. So for example, a weight scale, blood pressure device, a thermometer, like all those different devices. The W stands for wearable, and even those are very different from each other. You have the watch, you have a necklace, you have a t-shirt, underwear, and so it's very big market there. You also have the S from sensors. So sensors are, for example, on the fridge, on your toilet, on your bed. You can see how much times you open the refrigerator, so if you eat, that kind of stuff. And the last one is the C from camera, and that can be just a normal camera or infrared, and those are mostly used for fall detection. And also this one I tried to make more visual. So in the left down corner, you can see the different types, so the wearables, sensors, cameras, and devices. And then from left to right, it's from data collection to an integrated intelligent response system. Oh, I think I missed like half of what it was here. So sorry, going back. Because I also did the number of abilities. So from just the third row, just only the heart rate and blood pressure, to everything, the form of abilities. So do they measure the vitals? Do they measure motion? Do they measure GPS? And then is it one device or is it multiple devices? Do you have to wear the watch and the necklace and the t-shirt, or is it just one thing? Then is there a platform around it where you can see all your data? All of those services of all of those companies have that. But then the next step is, do they actually have a service or a response around it? So is it just that you can see on your smartphone, my heart rate was this today? Or is there actually someone watching that data, and if something's wrong, it's responding to that data? And the last column is AI. So is it someone, is it a doctor or a nurse watching that data, or is it being helped by AI? So again, we get to the visual. So from data collection to an integrated response system that actually, if something happens, someone is going to come to you. From low number of vital signs monitoring to a high number of vital signs monitoring. I wanted to talk a little about 3 different companies that I looked at. So the first one is in the right upper corner, is Hexoskin. They are wearables, t-shirts, intelligent textiles. So they have t-shirts, underwear, and it's amazing because you can just put it in the washer, no problem. And they have a very high number of vital signs monitoring. So how I see it, this would be perfect for post-op. It's very medical, very detailed, but might not be necessary for the long term for chronic care. Then you have MySense, still on the right, most on the right. And MySense, I think, is more for the chronic care, because they have a watch that does your heart rate and just your heart rate, but they have the sensors like, are people getting out of bed? Do they eat enough? How much time are they on the toilet? that kind of stuff. Then you see Cloud DX. It starts at the left and has an arrow to the right. I don't like them yet because they have several different devices at the moment, but they definitely are going to the right upper corner because they're rolling out a new technology beginning of next year. It's a necklace, just one device that continuously monitors everything. And what I extremely like about this company is that for every single use case, they are going to sit with that organization or with their clients and are going to look how can they design their technology around your specific use case. So they have a use case in ambulance, helicopter, but that's different from, there are a few different examples, but they actually come to the company and say, what do you want? We're gonna give it to you. So I like that a lot. So I spoke a lot, very fast. To summarize, I had 20 different solutions in those 5 buckets. And that's a lot of information and a lot of things we can focus on. But I made my own, my personal conclusion is here. I think that there are 6 things there are prime solutions we should focus on. And the very first one is remote monitoring, because this one will enable all the others. This one will enable the early discharge. It will enable the palliative care. And those, like the early discharge and the palliative care, are important because you don't want those people to stay in the hospital if they don't need it. But in order to get them out of there, you need the remote monitoring to actually give them the care they need. The second one, at-home diagnostics. At-home diagnostics, it's much more comfortable. It's less cultural discomfort. It's less of a burden for caregivers. They don't have to take their partner or their loved one to the clinic. They can just do it at home. And what's important is at-home diagnostics, it gives better access. So clinicians and doctors can actually base their treatment on the right information, and that will save a lot of money in the end. Which I like. The other thing I like is virtual trials. I really think that it will disrupt the whole business because the timeline is like a fifth or even less of what it is now. And because I did this research for SE Health, I think they already have the right structure in place, the nurses, to help with those virtual trials. And the last one, VR therapy, because it can be used in so many cases. And the one I like is with social isolation, which is definitely one of the problems with the elderly right now. And to be honest, I just think it's a very cool technology. So these are the things I think at least SE Health should focus on. I tried to look up your Alberta Health Services, but the website is down, I think. Or maybe it's the connection.
I don't know. It might be. I'm going to open up the... Thank you, Bregje. I loved it. I'm blown away. I didn't realize this much was going on. I'm going to open up the floor for a few minutes, and then actually we're going to hop into a breakout. So who has a question for Bregje? You can say Bregje or B.
Whatever works, yeah.
Initial reactions. Make it good. Go. Nobody? Questions? Hello?
I was just going to ask you a quick question. Was most of the innovation coming out of the States? And was there anything in your research that kind of suggested why they're pushing so much farther than everywhere else?
I wouldn't say everywhere else. To be honest, I think Canada has it quite difficult for innovation. They have a difference. For example, if you take the Netherlands versus Canada, the Netherlands has a insurance-based healthcare system. And so every insurer wants to make sure their healthcare costs the least. So there's more motivation to start innovating because they can compete better with their competitors. Sorry, but and in the US, there's a lot more money than in Canada. So yeah, I think Canada is difficult. There's different incentives, exactly.
Mm-hmm.
And for example, the early discharge is a big thing in the Scandinavian countries. The phlebotomy is in the Netherlands. So yeah, I think the US is definitely ahead, but there are interesting things in Europe as well.
Very interesting. Who's next?
Sorry, this is Selena Bandera. I work in primary healthcare. I have a question.
Yes.
Fantastic, great.
Sorry, I can't hear the question. Could you speak up a little?
Yeah, can you hear me now?
Yeah.
Okay, sorry. This is Selena Bandera. I work in primary healthcare as a senior consultant at AHS. Thanks a lot. It was a great presentation. Along the lines of this question of sort of who does this the best, what do you think the implications are for this new Canada, this Can Health network that was announced sort of earlier this month, I guess?
To be honest, I didn't focus on.
It's a federal announcement. Yeah.
Yeah. So it's a network of different health systems to help this kind of work go quicker.
Yeah.
Is that what's sort of missing in Canada?
No.
Yeah, to be honest,
No.
No.
I didn't look into this specific because for the barriers to innovation, I looked mostly for Ontario because SE Health is that's the most important region there. But one thing I thought was why people were optimistic was the Ontario Health Teams. I don't know if you know about that.
Yeah.
Yeah, so that is, I don't know if it's something like similar, but that was definitely something that that got people optimistic. They said, if you asked me like a few months ago, I would say like, don't even do it in Canada, start somewhere else, bring it to Canada then. But there are definitely some movements that are incentivizing innovation in Canada. For example, the OHTs, but I haven't.
Yes, okay. All right, I'm going to ask everyone, we're going to hop you into a 7-minute breakout. It's going to be automatic, so you're going to see a message that you say yes, but the question for the breakout is, how might we incorporate these innovations in Canada? Like, what is preventing us from adopting these? So you're going to get the cue right away, and you'll come back to us, and I want you to think of one thing per group of what you want to say about how we can incorporate these innovations in Canada. I'll see you in 7 minutes.
You'll see a join button. Just click the join button. You can join anyone. You might be able to join anyone. Did you click the join button?
But I still like struggle because a lot of those technology.
Hello, Mark. Just the two. I don't know. I just see the two of us for now. I don't know.
People have to.
So what do you think of that? That's a great scan of what's going on, isn't it? Hey, Mark, what's our key message from our group? There's two of us. You're muted. Yeah, you're muted. It's okay.
Okay. So we're back to the main group.
We're back in the main group. Hello, everybody.
Hello.
Hello. Okay, I'll let everyone trickle in.
Oh, crap. Am I still sharing my screen?
Everything.
No, it's just your
Okay.
face now.
Okay, no, that's good.
Were you in a breakout group, Bregje?
Yeah, but just one other person.
I don't know what happened there.
People are in some.
Oh, we had an interesting talk, so.
Oh, interesting. Oh, we had a lot of drop-offs too. Okay, I want to hear in the last 3 minutes, what was there a gem in your group that came out? How can we incorporate these innovations in a Canadian healthcare setting? Any thoughts? Who wants to go?
The
Richard?
Mollies.
Yeah.
Yeah, I mean, so I was talking to Tommy from Edmonton, who used to work with home care. I mean, it's interesting. A lot of the things that B was talking about are already happening. So the
Yeah.
community paramedic teams are doing palliative care,
Right.
doing blood work, and they're also doing something around frequent flyers, that kind of intervention. So
Yeah.
the structure is there. It's just we're not spreading it.
Ooh, interesting. And yeah, people are still dying in hospitals. Yeah. Interesting. All right, who else had a good gem?
I can talk about what me and Joe were discussing.
Go ahead.
Sure, yeah. So on that topic of things already happening and the inability to scale things that are already happening, that seems to be an issue with 12 different health care systems essentially in Canada. One thing that's bothered me about this issue of scaling is understanding what it is that's already happening in other places. And coming from a health system researcher perspective, for me to understand what's happened, so like to go through a sort of archaeological dig of what has happened in any given specialty, it's very hard to find that information for a couple of reasons. Number one, going to just see where that stuff is reported. If it's not in the literature, you'd look for sort of what's going on the different health systems websites even, and that's been a nightmare as healthcare regions change. So this is what I was using Saskatchewan as an example. Recently, the number of regions collapsed into one, and with all of the reports that had come out as to the innovations that were happening in each of the health regions, they all sort of disappeared, and all the links died when all of the regions collapsed into Saskatchewan Health Authority.ca. All those links disappeared with all of that institutional knowledge about what's happened already. And
interesting.
So that's a problem.
Thank you.
Yeah.
Good. Anything else, Selena?
Yeah, and another thing is trying to ask people what has happened. If you were to go into health regions and ask people what has already happened in the last 10 years, there's so much turnover and people move around so much that there's, at like a workforce level, there's no institutional knowledge to know where things have gone and what has gone wrong in different places. People move around a lot. So
yeah, interesting. I have 11 o'clock. Ali, do we need more reports to share knowledge or more meetups with great minds to diffuse knowledge? Do people feel like there's enough of a connectivity?
no.
Definitely not.
Okay.
Or I'm not in those groups. It may
Right. Well, you're now in the group. You're invited.
Fantastic.
That's interesting. And Mark Leduc, he's part of the innovation group of AHS. This connectivity amongst us around these new innovations. Okay, Ali's just told me he's going to post this recording on YouTube. Bregje, many of us want to stay in contact with you. Are you okay if I send out your email address?
Oh, definitely. And I just wanted to say again, this was the global scan I did. This wasn't all of my research. I did a deep dive as well on the remote monitoring as the at-home diagnostics. I will have my report ready in the beginning of October. So I'll definitely, if you send me an email, I'll send you the report. And in that report is also advice on how to increase implementation. How can we actually make sure? So that was one of the questions I heard popping up just now. So
yeah,
I hope I can give some information on that as well.
Excellent. And are you okay if we share this recording and your PowerPoint?
Yeah, no problem. Yeah.
Awesome. I want to thank you for taking the time, Bregje. I know it's early evening there and you probably want to enjoy the summer. I want to thank everyone for joining this call. We'll circulate this recording and the PowerPoint, and let's stay in touch. And it sounds like we need a bit of a definitely Alberta-based network conversation about innovations and the adoptions of new technology and different business models. All right, thank you, Bregje. I appreciate.
Yeah, thank you for having me. And